Okay, so good evening, one and all, and thank you everyone for joining in this session. So this is going to be a journal club type format. So we're going to discuss a trial, the Andromeda Shock True trial, and we've selected this trial because we think that it could have some conclusion that can change the way we practice, and it has some other few interesting statistical tidbits that we feel is worth discussing. So, I'm Dr. Mehul, Senior Resident in the Department of Emergency Medicine, and helping me will be Arvind sir. He was my senior here in our department. He is currently working in Mumbai. So, without wasting much time, we'll proceed on to the topic. So, to understand this study, we have to understand the initial Andromeda Shock trial. So, what they basically looked as was comparing using capillary refill time as a value target in substitute compared to the usual method of training the lactates of the patients. And what they found out was that using the capillary refill time, they were actually able to reduce fluids and had some signal towards lower mortality in the CRT group compared to the lactate group. So that is a basic hypothesis generating trial. I don't think anybody will change their practice based on that, except for perhaps having a higher emphasis on looking for the capillary refill time. But this trial was basically taking it one step further. And what it did was try to look at a personalized hemodynamic resuscitation strategy. So we'll get into what exactly that means in a little bit. So where they looked at whether this personalized protocol actually improved outcomes in septic shock compared with your usual care. So there are basically four pillars of Andromeda Shock 2 trial, or four basic principles you could say. So number one is that what they're targeting is basically CRT normalization. So what they're not targeting is like specific map targets or something. They are basically targeting CRT normalization. So they're looking at the optimizing the physiology, not just optimizing the numbers on the monitor. Now, next thing is that they are trying to identify the underlying patterns of the key cardiovascular dysfunction in each patient. For example, some patient will be having a cardiac dysfunction as part of their septic shock, so septic induced cardiomyopathy. Sometimes they are having more of a hypovolemic picture. Sometimes they might be having a vasoplegia. So septic shock is like a very broad term, and patients can have different manifestations depending on where they are in their disease course. So they try to identify these different patterns using both clinical as well as your bedside ultrasound tools. Next is they assessed fluid responsiveness before they gave any fluid. So earlier, it's not earlier, even the latest surviving sepsis guidelines recommend 30 ml per kg in all septic shock patients blindly. So this is somewhat moving away from that and looking at more of an individualized approach and looking whether the fluid is actually going to improve the hemodynamics of the patient, and if there is evidence that it might, then you give the fluid. And we'll discuss how exactly they looked at fluid responsiveness here. And lastly, they use something a little bit out of the box, which is use of short hemodynamic stress, like a higher map stress test or a dobutamine stress test, if nothing else was working. So some of these things are things that a lot of us were actually already doing, even though it is not technically in the guidelines as such. But once the usual things are not working, then you'll have to, go think out of the box. So these are not exactly new for us, but this is the first time that all of this is being studied in protocolized trial like this. So we have to go into the design right now. So whenever you find an RCT that you think is interesting and could change your practice, you have to actually go into the methodology that much in a little bit detail. So when you're looking at study, because a lot of studies get published all the time, so every study is not going to be worth going into a lot of detail. So that is why you read abstracts. You read the abstract and you get an idea whether this is a good sounding study and it's a practical study and something that might be applicable to your practice. Then you will have to go into a little bit of more detail to see whether it is really applicable for the patient that you're seeing. That is why you have to discuss things like the methodology and all. So the design is basically multi-center open label RCT. What does open label mean? Basically, it was an unblinded trial, and we'll discuss why that was the case. It was basically in concordance with the concert guidelines. Many countries, 19 countries over multiple continents. Why is this useful? Because the more different environments this was tested in, so improves your external validity. If it was just done at one single hospital with the very expert level staff, very experienced staff, it may not be, you know, uh, replicable in some other setup where the people may not be that much trained, or in a different kind of health system. But since this has been done in multiple settings in multiple continents, you can assume that the external validity should be somewhat good. So it was conducted over a 3-year period. So coming to the population, so basically they included patients with septic shock who have not responded to IV fluid and are on NORAD. So every patient on this trial was basically on NORAD to try and maintain MAT more than 65. It was not an exclusive ED trial. It was not an exclusive ICU trial. They also recruited patients from wards and operating theaters as well. Exclusion. So basically, a lot of trials will exclude patients who are going to have a very bad outcome no matter what you do. So patients with having child C cirrhosis, active malignancy, already DNR status. So these patients were not included in the trial, and this is not surprising. This is what usually happens in most of studies looking at things like septic shock and all. So they also excluded patients more than 4 hours after, if there was a more than 4 hour delay after meeting the septic shock criteria. So most of the patients were actually recruited very early, which is actually a strength of the trial. So what they did was a central web-based randomization in a 1:1 ratio into the CRT PHR group or the usual care group. The trial was unblinded because basically you're doing a very different thing. So it's very difficult to actually blind either the patient or the clinician as to what was happening. So important thing is when you're talking about CRT and a trial on CRT, even though all of us are doing it, there's a lot of subjective variation to something like this. So what they did was actually, have a very strict way of how to actually measure the capillary refill time. So what they did was they applied firm pressure to the ventral surface of the distal phalanx of one of the patient's fingers, and pressed it with a glass slide, and it was blanching, and it was maintained then for 10 seconds and then released. Then they measured the time to return to a normal skin color. So this is actually bit more complicated than what we usually do to measure a CRT. We usually just have a visual estimation of whether it looks like more than 3 seconds or not. But these people are actually time the actual number of seconds it took for the color to return back to normal. So if you are wanting to actually apply this into your clinical practice, you have to consider actually taking this somewhat seriously, how to measure the CRT. So to move forward, we have to understand exactly what they did in this study and exactly what their protocol was. And this is going to be a little bit difficult to understand, but I'll try to break it down as far as possible because it's a very big protocol actually. So basically, they had tier 1 and tier 2 things. Tier 1 is mostly clinical with a little bit of ultrasound, whereas tier 2 is more ultrasound based, and then it goes to some out of the box things like your various stress tests. So in tier 1, what they mainly looked at was one was the pulse pressure. So if the pulse pressure was less than 40, that is generally a low cardiac output state. So in that case, they will assess whether the patient is fluid responsive, and if the patient is fluid responsive, they'll give around 500 ml of fluid over 30 minutes, and maximum up to 1 liter before reassess again. If pulse pressure was more than 40, but your diastolic pressure was less than 50, then they will increase your NORAD to actually increase your diastolic blood pressure to more than 50. So these are the tier 1 things that I actually did to actually improve the CRT. So in the CRT group, they were basically reassessing CRT regularly about every hour or so. If these um, things fail to improve the CRT, then they will move on to the tier 2 strategy. So the tier 1 strategy is basically, one is pulse pressure, second is diastolic blood pressure. So how do they actually assess fluid responsiveness? So this was not fixed. So any of these things could be used: pulse pressure variation, stroke volume variation, passive leg raise, VTI, distensibility index. So not collapsibility index, it's distensibility index in your intubated patients, and end expiratory occlusion test. Any of one of these they could have used. Another one not that recommended compared to the other one was passive leg raise with pulse pressure variation. So these are the basic things that was described for this trial, and you can find these things actually present in the supplement for the study, not in the actual paper published in JAMA. So this is actually good, I feel, because frankly there is no one gold standard for assessing fluid responsiveness. All of these things have you know caveats to them. For example, most of these things like pulse pressure variation, stroke volume variation, they have a lot of caveats. The patient has to be in sinus rhythm, they have to be intubated, they have to have a tidal volume of like 8 ml per kg, etc., etc. Lots of caveats for them to be actually eligible to be used. So relying on only one of them, probably not the most ideal. So having multiple options is actually a good thing, but again, from a trial point of view, it makes things a bit more complicated. Moving on to tier 2. Tier 2, first of all, you look for cardiac dysfunction. Cardiac dysfunction can be RV dysfunction or LV dysfunction, and based on whether they have either of those, you treat as indicated. Okay, so what they have not done is actually specify how to actually treat the condition. So that was left to physician discretion basically. But the tier 2 basically started with looking for any cardiac dysfunction. If there is no cardiac dysfunction, you can again look for fluid responsiveness. And if the patient is fluid responsive, you again can give fluid boluses. If that also does not work, or the patient is not fluid responsive, and the patient is having chronic hypertension at baseline, they can consider something like a MAP test, where you target a higher MAP of around 80 to 85 instead of the classical 65 for about 1 hour. Another thing you can try is a dobutamine stress test, if that is for around 5 microgram per kilogram per minute for about one hour. And again, the CRT will be reassessed after this. So basically, you have continuous reassessments after each of these maneuvers. So RV-LV dysfunction, how do they define it? So they've in this study, LV dysfunction, they've given us a fractional area change less than 40% with a aortic VTA of less than 14. Don't confuse it with LVOT VTA. Aortic VTA is actually something else. RV dysfunction, they have defined as an RV-LV ratio of more than 1 plus a central venous pressure of more than 8. So a combination of both of these two was considered as RV dysfunction, and the other two was considered as LV dysfunction for the purposes of this study. Obviously, there are multiple other methods for looking at LV and RV dysfunction. So again, this is the flowchart given in their trial paper. So again, tier 1 and tier 2 is given here. So basically, tier 1, you're looking, everything starts with the CRT. If the CRT is normal, you're not going to proceed with any of this. You're just going to monitor the patient every hour or so. So in tier 1, you have a pulse pressure and a diastolic blood pressure. Pulse pressure less than 40, look for fluid responsiveness. Diastolic less than 50, increase your noradrenaline. Tier 2, look for cardiac dysfunction. No cardiac dysfunction, you can again consider fluid bolus. If fluid responsive, still not improving, you can consider MAP test or a dobutamine stress test or an inodilator test. So that was a protocol. I hope that made some kind of sense, because a lot of things were actually going on there. It's not a simple RCT where you have just one intervention, that you're just giving one drug and seeing what happens. These are actually multiple intervention and multiple levels of intervention. Even though this is just say 2 tiers, there are actually multiple things going on here. So how did they actually implement this kind of a protocol? So actually they gave mandatory training for all of the clinicians who participate in the trials, and they were called trained medical operators, and they use multiple methods of teaching them, like videos, manuals, scenarios, etc. So different groups were basically managed by different people. So the CRT the PHR group, they were managed by these trained people, trained for the protocol, and the usual care group was managed by the usual attending intensivist. So the different people were basically managing both the groups, and this might introduce some kind of bias here, but uh, protocol adherence was assessed weekly. There was a dedicated team for addressing the protocol adherence. Control group based gave treatment as per the local or international guidelines, and basically the whole trial looked at around 6 hours in the resuscitation process. So it is from 0 to 6 hours. They didn't actually look at anything beyond the initial 6 hours. So again, the protocol was complicated. The primary outcome is also kind of complicated. So in the primary outcome, they use something called a hierarchical composite outcome. So hierarchical composite outcome, and they stratified it by Apache score. So I'll explain this in a coming slide. So basically, the hierarchy for this outcome was that the topmost was mortality at 28 days. Second was duration of life support at 28 days. And third was length of hospital stay at 28 days. So they will compare each of these in both the groups. They compare pairs in both groups to each other and see uh, whether one is better than the other for each of these three things, with the preference given to the first one, then the second one, then the third one. So that is how this works. So patient in the treatment group compared with all the patients in the control group, one pair at a time. So first of all, they compare the mortality. So if only one survives, this will be counted as a win for the survivor group. So whichever group the survivor belongs to. If both died, then it is considered a tie, and then you don't actually go below that. It is only considered a tie if both patients die. So if both survive, then you go on to the next level, and that is when you look at the time to cessation of vital support, like your intubation, vital medication, etc. Then third is number of days of vital support, uh, and that is basically length of the hospital stay. So, and how they express this outcome was in something called a win ratio. So win ratio, what they looked at was they compared the number of wins in the experimental group by the number of wins in the control group. So obviously, if there are more wins in the experimental group, that means the experiment group is actually doing better. So the win ratio of more than one will actually favor the experiment or the treatment group. Whereas if the win ratio is less than one, that will favor your control group. Okay. Secondary outcomes, what they look was mortality at 90 days, vital support free days at 28 days, and length of hospital stay at 90 days. So there were also tertiary outcomes that I looked at, but that was more of like exploratory kind of analysis, and I'm not going into detail of that. Power calculation, how did I actually calculate the sample size, basically, they assumed a 28-day mortality of 39%. 39%, how did they get this? They got it from your original Andromeda Shock trial. So that was how they came up with that number. And they assumed the CRT-PHR group would reduce mortality by around 6%, which is frankly very, very optimistic in the world of critical care to think that something is going to reduce mortality by a whole 6%. But anyway, this was based on what they had found out in the initial Andromeda Shock trial, and they had found a sample size around 1,500 for the same. So around triple that were actually assessed, and various patients were excluded based on your exclusion criteria. Around 1,460 were included in analysis. Most of them coming from your Americas and the Europe, with only a few coming from Asia. So this was the study flow chart. So around 750 patients each were allotted to each group, and if you look at it, very few patients were actually lost to follow, which is actually a strength of the study. So around 14 in one group, 6 in another was lost to follow up, and few other patients withdrew consent. So very, very little lost to follow up in this particular study. Statistical analysis, we already mentioned they're using the win ratio, and they use the Apache score as a stratifying variable, because you want to assess patient groups which are actually somewhat similar to each other. So they used to Apache score to differentiate patients who are more or less sick. So Apache score more than 19, less than 19. That is how they actually stratified these patients. Otherwise, you're just introducing all kinds of bias if you don't certify them. So is this actually a better method than a usual composite outcome? So to understand this, you have to understand what exactly a composite outcome is. What composite outcome usually means is that you have one outcome, but it's actually saying four different things. So primary outcome is a composite of four different things, like patient dying at 28 days, or patient being hospitalized, or patient needing a renal replacement. You're mixing a multiple things into one outcome. Now the problem is that if you have mix similar things together, then it's fine. But usually what happens is that one of them will be very bad, like dying, and the one of them will be somewhat of a vague and subjective outcome, like hospitalization or ED visits, which can happen for a number of benign reasons also. So this might fool you into thinking that the interventions have a mortality benefit when they actually didn't have a mortality benefit. So this you are basically having unequal things being jumbled into one outcome. So this can be problematic. The hierarchical outcome, it tries to solve this problem by giving weightage to the more important thing. So mortality is given more weightage compared to something like length of hospital stay. So obviously patient will care more about whether they live or die more than the number of days they stay in the hospital, comparatively speaking. So this helps to solve some of the problems with the composite outcome, but it doesn't really solve all of the drawbacks of a composite outcome completely. So the secondary outcomes were presented as something called hazard ratios. So this can be a confusing term, because there's something called hazard ratio and there is something called risk ratios, and they're actually somewhat different. So a risk ratio is basically looking at the number of people who have had particular event, or for example death, in the treatment group compared to your control group. So when the patient had the event in during that particular time period, for example 28 days, doesn't really matter when you're considering a risk ratio. So whereas when you are having a hazard ratio, it is actually looking at the time period as well. So things that happen early on in that 28 days is given more significance compared to something that happens later on. So there is a difference between early adverse effects and something that happens later on, because we like to assume that the really important side effects generally will happen a little bit faster than maybe 25 days down the line. So that is where the hazard ratio comes into play, and that is why the hazard ratio is somewhat different from the risk ratio. And risk ratio is basically a simple proportion. Whereas for hazard ratio, it's actually a much more complex thing, and you'll have to do a statistical tool using Cox regression to actually calculate this. So when you're talking about risk ratio and hazard ratio, even if they have the same number, the meaning is actually somewhat different. So if the risk ratio is like 0.67, means that there's actually lower risk of the event. So if risk ratio is more than one, it is having higher risk. Less than one, it's having lower risk. If it is 0.65, 33% lower risk of that particular event. But hazard ratio of the same number doesn't mean that the treatment group had 33% less number of events. So that doesn't meaning is actually not the same. So that is a small difference between risk ratio and hazard ratio. Hopefully, Arvind sir might explain this a little bit better in a little bit. But this is basically my understanding about these two statistical concepts. Now, baseline characteristics, coming back to the study, baseline characteristics between both groups were mostly similar. These were mostly elderly patients in their mid 60s. They were most of them were quite sick. The groups were very well matched. Most of them having abdominal sources of infection. All of them were on NORAD, and about one fifth of them will be were on vasopressin, and half of them were intubated. So we can be sure that these were all actually pretty sick patients. So one of the things you have to do when you're looking at a study on septic shock is to see how sick the patients were. So because sometimes you can have patients who are not very sick to begin with, and then any intervention you do on them will have it's very debatable meaningfulness, you could say. But these were basically quite sick patients. So how did the management differ at the end of the study period, which is around 6 hours? That the vasoactive medication were more or less the same. More dobutamine used in the treatment group as expected. Less fluid used in the treatment group, but it was only around 250 ml less. How much of a difference is 250 ml on average going to make to the average patient? I'm not really very convinced that it's going to make a huge difference. Lactate was lower in the treatment group. CRT was shorter in the treatment group. So somewhat there is a trend towards the treatment group doing better. So what we really want to know is the primary outcome, and the primary outcome was was a uh, was positive, and it was statistically significant, and the win ratio was more than one. So the treatment group was shown to be better, but it was not due to any mortality benefit. It was basically driven by the hospital stays and the lower the hierarchy outcomes. So it was not actually a difference in your in the mortality. So mortality between the two groups was actually the same in the secondary outcome. There wasn't any huge difference in the length of stay, even though it was like almost 1 day less in the treatment group, and the vital support free days was also around 1 day more in the treatment group. So even though study is positive, the benefit shown is like kind of marginal. So around one 1 day earlier, maybe the patient got off vasopressin, or 1 day earlier the patient got off the ventilator. So the conclusion was that this was basically a positive study, and that it was a practice changing study. And there's a lot of things that we can discuss about this. There's a lot of strengths of the study, which was a very well done RCT. It's very difficult to do this kind of RCT with such a complicated protocol. So definitely hats off should be given to the people who conducted the study. I can only imagine how difficult it must have been to coordinate all of this. So other than that, they used patient standard outcomes. They were building on the information that they had on based on their own prior study. The randomization was fast, so within two hours of meeting the criteria, the patients were started in the treatment and control groups. The proper training appeared to be given to the participants. The statistical analysis plan, even though a little bit complex, was actually defined even before the start of the study, which is what you're looking for. And win ratio, again, there are pluses and minuses, but it is definitely improvement on the usual composite outcomes that we see. Overall, the protocol adherence was good, not much protocol violations considering how complex the protocol actually is. Loss of follow-up was very less also. Loss to follow-up was actually very less also in both groups. Weaknesses, first of all, it's an unblinded trial, so that by itself will introduce a lot of biases that we cannot actually fully account for. CRT by itself can have some inter-observer variability, although they have taken a lot of strain to make sure that that is minimized as far as possible with their protocol. Fluid responsiveness was the way it was assessed was not standardized everywhere, so they had multiple options in exactly how they would want to do that. So, and there are other things that actually influence the primary outcome, like when they would stop the vital support and all of those things. So that can again be subject to bias because that was not, very fixed on what should be done. So that was basically based on local practices and all. So another weakness is that even the primary outcome was positive. It was basically due to the relatively less patient important outcomes. So short, shortening of organ support or length of stay by around 1 day. Is that good enough to justify a protocol that is this complex? It is debatable. Another big problem is something called bundle effect. What do you mean by bundle effect? Is that this protocol is introducing multiple things together. You are having multiple interventions. A lot of them that are actually not standard of care. MAPS stress test, dobutamine stress test, increasing diastolic blood pressure. These are all frankly new things in the world of septic shock. So which one of these things is actually the most beneficial? Are all of them beneficial? Are actually some beneficial, some harmful? We don't know. And that is one of the biggest problems with this kind of trial. And the biggest criticism has been raised against the MAP test because studies have shown that higher maps is number one not beneficial, and one RCT in Japan actually showed increased mortality by targeting higher maps. So this is one thing that probably we big negative for the study. Again, I think these studies were published after this trial was actually began, so it's not a fault of the authors, but again this limits the applicability of the protocol in our everyday practice. So maybe we should incorporate some of these things in our practice, but not all of them blindly. So again, it's a complicated protocol. How will you apply this in a very resource limited setting? Up for debate. I don't think it's like impossible to implement it, but again, you do need some kind of specific training to actually apply this properly. Whereas the usual sepsis guidelines saying that you should give 30 ml per kg to everyone, that anybody can do that because that there isn't much brain work going into that. Generalizability, even though it's a multiple continent thing, a lot of this is based on patients in Spain and Latin America. So it's basically more relevant to that area and those local practice patterns than it is elsewhere. And now I think I'll just take it over to leave it over to Arvind sir, so to give his thoughts on this trial and what he wants to comment on. Sir, you can take over now.
Thank you, ma'am. Thank you. Yeah, good evening, everyone. I'm Dr. Arvind. I am an emergency physician, currently working as a clinical associate in the Department of Critical Care at BD Hospital, Mumbai. So that was just for a brief introduction about myself. Thank you, Mehul, for a very detailed, uh, you know, dive deep, I would say, into uh, the Andromeda 2 trials. Definitely a huge trial. It's a landmark trial as well. So I think he has covered most of the topics. The brief given to me was just to provide a little bit of an understanding in statistics. So this disclaimer right at the start that I am not uh, exactly a statistician. In fact, I'm not a statistician. So if there are things that you haven't understood from my explanation about this, or if there are things
Sir, I think you got your audio is
yeah,
gone.
it's not, we still not. Can you hear me now?
Now we can hear you.
You can hear me now. Right?
Yeah,
So
yeah, okay.
some connection issue. So as I think my brief will be to provide a little bit to the so I'll be focusing on your hierarchical composite outcomes, but how you see the win ratio and all. Useful in this trial and why you have to be cautious with using it. That is the first thing. I'd also provide a little bit of an insight into risk ratio and why both different. So these are the things I'll just brief over, and then about this trial we'll discuss.
Okay, I think sir, sir's audio is something.
You hear me now?
It's still a bit grainy, sir.
Okay.
Audio. We can hear you, but it's like
Okay. Let me
getting
just try.
cut off.
Let me just try once again. Just give me a minute, please.
Sure, sure.
Recording in progress. So Mehul, right? Now, can you
Yeah,
hear me now?
now it's better. Now it's better.
So that you can be able to screen share right now. Right. So I'll try to explain what all is going on over here, and any doubts that you have or anything that you feel I need to clarify a little bit more, please you can stop me during my explanation itself. All right. So, right. First off, coming to the understanding, we all know why composite outcomes are used, right? The most common composite outcome that I think we would have probably seen are your MACEs, right? Your major adverse cardiovascular events. So if you're looking, why do you need a composite outcome in the first place? Your outcomes of, suppose you want to study the effect of some medication, say a DAPT, on your incidence of heart disease, and you want to see what are the possible cardiac complications can happen to your patient. So, what are the possible cardiac complications? You can have a sudden MI, you can have a sudden stroke, you can have a death as a result of any of these. Or you can have, say, some angina or some unstable angina, which, or maybe some ECG changes which mandate plastic or the aging, whatever it is. So I'm having to study each of these outcomes. Your entire power calculation, sample size calculation, your analysis becomes complicated, right? Your entire study becomes extremely resource intensive as a result of this. So what happens? I am in effect studying one outcome, all these together into one single outcome. And that is known as a composite outcome in very simple terms, right? So in a composite outcome, if a patient is having any of these four, that is, if the patient is having a death, or he's having a sudden MI, or he's having a stroke, or he is having a new onset plastic requirement, say, I am going to say he is positive for the composite outcome. It is a yes on the composite outcome. If he has none of these, it is going to become a no. Now my powering, my sample size calculation, my statistical analysis becomes so much easier. I just have to calculate a relative risk or odds ratio, maybe do a regression analysis, a correlation regression analysis I can do, and immediately I have a full formed statistical plan for this. So this is what happens when you use a composite outcome, and that is why composite outcomes are preferred when you want to study multiple outcomes which indicate probably the same coronary circulatory dysfunction, probably in this case. Right? Am I clear up till this? So now we'll move. Why do we need a hierarchical composite outcome? In this particular case, if you are looking at two patients in the study, right? One of them has presented to you with sudden cardiac death and he dies. When you start CPR, he dies. The other patient has come to you with a stroke with an NIHS score of 0. He started on single antiplatelet status. He returned and your is completely score is 0, extra, extra, extra. Now, if you are looking at your statistical analysis for this study, both of these patients outcome, yes, both of these patients will have an outcome positive when you're doing your analysis. But do you think that is fair? A patient who has died as a result of a coronary event and a patient who has had a very minor non-disabling stroke are grouped together when you have a composite outcome of this nature. This is where the problem with composite outcome. In other words, the severity of your outcomes are not hierarchical or ranked. They are all considered. If you or a stroke, or if you die, or if nothing happens to you, also it can still be sick. And that's why you have a problem with composite outcomes. It is to address one more problem with composite outcomes is that, for example, here you have outcomes of the same type, right? Now, if you want to include a temporal outcome in this, say you want to include hospital length of hospital stay in this. Suppose you want to include, you can't add that to this. That will become a secondary outcome. You cannot add that to a composite outcome, which is composed only of binary variables already. Because if you add length of hospital stay, it's a continuous variable. All of these that you're looking at, whether the patient had an MI, a stroke, they're all categorical variables, not binary variables. You can't club these two together to make a composite outcome. So if you want to study hospital stay, it becomes a separate secondary outcome. And your study is not going to be powered for that, obviously. So that becomes an exploratory result. Am I clear about the drawbacks of composite outcomes till now? Higher composite outcome. So, in order to address these defects, what we decided to, not me, but this was first introduced by a scientist called Pocock et al. In 2012. They came up with hierarchical composite outcomes. So, what they did was to rank your outcomes out of your composite. It is still a composite, but you're going to rank them. So, the most severe in this maze that I'm going to is first, I'm going to take death. If the patient dies, that is my highest priority. Second, I'll take an MI. The third, I'll take a stroke. And the fourth, I will take a new onset plastic event.
So now I am really clear as to where I should place which outcome I should take more seriously. If the patient has died in one arm, there's no point looking at any of the rest of it. If I'm focusing on the treatment arm and in the control arm, and if the patient in the treatment arm has died, I don't care whether any other things happened. This is all that matters. The patient has died. That is a now if the patient has, if both patients have not died, the patient in the treatment arm has not died, the patient had an MI. Now the patient in the control arm had an MI. The patient in the treatment arm didn't have MI. That is a loss for the control arm. That patient has had an MI. If the stroke, if the patient in the control arm has and a loss for the control arm.
Sir, your
Hierarchies,
audio
right?
is still getting cut actually.
Are you able to hear me now? Able to hear me now?
Yeah, now it's better. Now it's better.
Okay. Yeah. All right. So in that way, I have looked at mortality. I have looked at an MI. I have looked at a stroke. And now the last thing I'm looking at, if the patient has had none of these, if the two patients I'm comparing now both patients have not died, have not had an MI, have not had a stroke, have not had a new onset plastic requirement. It becomes what we call a tie. So did you understand how this works? How now, if at any point of time you get a win, that comparison is stopped right there. You don't go any further because if the patient has had an MI, you don't go any further to stroke or new onset plastic. The comparison stops right there. Whichever arm has not had the MI wins, and whichever arm has had the MI loses. Am I clear about this concept? Is there any doubt about how a win is seen and how a win or a loss is calculated and even a tie? In the Andromeda 2 shock analysis, they did one thing which is very clear. Mortality upfront, right away. If both patients die, it is a tie and you don't go any further in this. It's a tie. There is no win or loss if a patient dies, which is very fair. Right. So in some analysis, what they do is time to death they take. And if the patient has died later, then they take it as a win for whichever arm in which the patient died later, which doesn't make sense in this case because if the patient has died within 28 days, it's a tie whether they have died at 24 days or whether they have died at 28 days. So that was the first different principle in this. The others were the same. You went into the other factors. That is, after this, you looked at the duration of organ support that was required. And if the duration of organ support was still a tie, that is the same number of days for the patient in the control and the treatment arm, then you went into the hospital length of stay. Am I clear about how a win or a loss is calculated in the Andromeda 2 statistical analysis? Now, in this way, you will compare each patient of the treatment arm with each patient from the control arm. And you will find out the number of total wins for the treatment arm and the number of total wins for the control arm. Then you do a win by loss ratio for the treatment arm to get what is known as your win ratio. This is how you arrive at your wins ratio. There are other parameters that you can calculate as well. There is something known as a wins odds. There is something known as net benefit. So we are not going to go into too much detail about this, but I'll just highlight one small point of this. See, when you're comparing a wins ratio, like I said, it's a win by loss for the treatment arm. Where do the ties come? In this trial itself, you had a 48% win ratio for the treatment arm, and you had a 42% loss for the treatment arm. A rest 10% are ties. Now they're technically not wins. right? They are technically not wins for the treatment arm. So you're completely throwing away that set of data when you are calculating your wins ratio. Do you understand the drawback that comes over there? A 10% of matchups which ended up in ties are completely ignored when it comes to the win ratio. Now, this is mitigated when you calculate something known as your wins odds, wherein you assign a zero 0.5 value for each tie. Then you'll take win plus 0.5 into tie by loss plus 0.5 to tie will become your wins ratio formula. I'm not going into too much detail of that. Then you calculate something called your net benefit, from which you calculate your number needed to treat in a hierarchical composite analysis. So, in simple terms, when you want to see composite outcomes where one outcome is where your outcomes can definitely be graded in terms of severity, and you may have outcomes of different types, categorical versus continuous, then you can proceed with your hierarchical composite analysis, in which you will see the calculate the number of wins and losses in the treatment as well as in the control arm, and based on that, you will calculate a wins ratio, a wins odds, or a net benefit. And from that, you will finalize your results. So in this case, if I have a wins ratio of say 1.17 in this trial, if I remember correctly, right? So 1.16, yeah. A 1.16 win ratio in this. So how do you interpret this? An overall win ratio 1.16 means that a patient in the treatment arm has a 16% more likelihood of a win rather than a loss. That is, a patient in the treatment arm has a 16% more likelihood of not developing one of these hierarchical composites as compared to a loss. Now, while this whole concept seems beautiful, and there is it is actually, the concept is really beautiful, but let me just highlight a small disadvantage. Not a small disadvantage, actually. When you understand the outcome of this trial, you'll understand why this can be misleading. Let's look at this. Now, you have gone to the secondary outcomes. Mail, can you just put up the secondary outcomes, please? Your overall win ratio looks beautiful, 16% likelihood of a win for a patient in the treatment arm. But when you're looking at your secondary outcome, you see that there is no significant difference in 28-day mortality, right? Your hazard ratio is 0.99, which is nothing, actually, which means that it's almost the same in both arms for your 28-day mortality. And your mean hospital length of stay as well as your mean vital support free days are just barely 1 day apart. And they are definitely not a significant effect size, I would say. And your mortality is completely almost neutral. So it is the less important outcomes or the less severe outcomes which have driven your win ratio to 1.16 and make the result sound good. Is it actually that good? Probably not. Probably not. If you look at your secondary outcomes, it's probably not that great. But if you look at just your win ratio, you exclude your ties, you're going to end up with a conclusion that the patient in the treatment arm has a 16% more likelihood of a better outcome, which is driven by just a 1 day decrease in hospital stay and vital organ support free days. So that brings into a little bit of a context that the benefit that you have actually gained from the trial, is it a worthwhile benefit or not? The benefit that the win ratio says may not exactly be worthwhile. So that is one problem when it comes to hierarchical composite analysis, that your lower outcomes, that is your less severe outcomes, may still be able to power the final result of your analysis. Obviously, hierarchical composite analysis comes with its own, complexity when it comes to statistical analysis and all that. And obviously, we're not going to go into all of that detail. And then, like I said, obviously, the win ratio, when you're using only the wins ratio, it completely ignores the ties in your statistical analysis. And that is a huge subset of analysis that you have actually been ignored in this study. So those are the problems that you can encounter with hierarchical composite analysis from a very simplistic and a superficial point of view. I will briefly touch on, by the way, before I go further, any confusions or any doubts that you want to ask about this? All right. If not, so I'll just briefly touch on hazard ratio as well as compared to risk ratio. Like Mehul had said, in hazard ratio is a type of survival analysis. Let's be really clear about this. Cox proportional hazards model, when you're going for it, it's a type of survival analysis. And any survival analysis, the difference between that and an odds risk or a relative risk is that it is done in comparison to time. In hazard rate, what you predict is the likelihood that the patient will have a hazard in the next unit of time as compared to your control arm. Whereas in relative risk, all you are saying is that I think Mehul had shown that a relative risk of 0.67 and a hazard ratio of 0.67. So how will I interpret it? If you are telling me that a relative risk of 0.67 is there for, say, a 28-day mortality, I'm going to say that the patient in a treatment arm or whatever it is has a risk of 60 has a risk of 67% as compared to 100% for the control arm of an event occurring in this 28-day period. That is all that I know. Whereas if I'm looking at hazard ratio of 0.67, I can say in the next unit of time, say it's 1 day, say it's 2 days, whatever it is, a patient in the treatment arm has a 67% risk as compared to 100% risk of the other person. Or in other words, 33% lower risk of an event occurring in the next unit of time as compared to a patient in the control arm. So in simple terms, a hazard ratio brings a temporal component into your analysis, whereas a relative risk or an odds ratio does not have this temporal component at all, apart from the pre-specified time period. So this is how you simply differentiate between a hazard risk and a relative risk. So if those confusions are answered, I think we can just go to the last slide that you were saying, Mehul. I think there were a lot more of points to discuss, but I think because of time constraints, we'll just restrict to that. So what I would take home from the Andromeda Shock trial is, first off, huge props to the trial coordinators, because it's an absolutely incredible study. 19 countries to have such less protocol violations, such less loss to follow up with such a complex protocol. It's not something that it is a great example of how a trial can be feasibly conducted. So that deserves huge props to them. So whether it is practice changing, see it very simply put, if you're a person who does practice personalized hemodynamic resuscitation for a septic shock, then maybe it's not practice changing for you. Then maybe it's just a little bit of modifications here and there. Here and there are things that you can try out. That is what you're going to do the next time you see a septic shock patient. If you're a person who still goes with your 30 ml per kg every time a septic shock patient comes, then yes, this is potentially practice changing for you. That would be my takeaway point from this. In this last slide, I just want to, this was by Josh Farkas. So in this, I just want to highlight a few things. You look at whether perfusion is adequate. So what Andromeda has been saying right from the start is that you got to look at peripheral perfusion markers like your capillary refill time. What do they indicate? They basically indicate your microcirculation. So sepsis is a condition where you're going to have uncoupling with your macrocirculation and your microcirculation. So your map is going to indicate your macro circulation. A map of 65 millimeter mercury will probably tell you that your macro circulation is fine, but it's not going to tell you about the state of your microcirculation, about how the individual tissues are going to get perfused, which capillary refill will probably be a much better indicator of. So that is why the Andromeda, showed, even on Bayesian analysis, Andromeda did show that there is a benefit for capillary refill time analysis. So a capillary fill time of less than 3 seconds, or you go with your usual urine output, you're going to look at all these factors before you decide whether to go for your vasopressors or your inotropes or your fluid challenge or a norepinephrine challenge. So it is going to be based on your fluid status, your cardiac function, which can be left ventricular as well as right ventricular, and your diastolic BP and pulse pressure. Simply put, your diastolic BP indicates your state of vascular tone, and your pulse pressure indicates your pulse volume. That is probably an indicator of your cardiac output. There are other concepts like your mean systemic filling pressure and your critical closing pressure and all that, but due to lack of time, we won't be discussing all of that. So in simple terms, there are three main functional phenotypes that you have to look at in a septic shock patient. So one is that the patient remains hypovolemic. Two is that the patient remains in a state of vasoplegia. in which case your stressed volume is very less. There is a predominance of unstressed volume and your stress volume remains very less. And the third is a cardiac dysfunction. Depending on which one of these you feel is predominant, or if it's a mix of all three, you titrate your therapy accordingly. And that is what is known as personalized hemodynamic resuscitation in very simple terms. How do you look for these? You assess the fluid status, you assess your fluid responsiveness, like we said with all these maneuvers, like your passive leg raising test or your PVV or your SVV. PPV or your SVV, your end expiratory occlusion test. All these will give you an indicator of your fluid responsiveness. And you'll obviously look at your diastolic blood pressure and your pulse pressure if you want to look for, your vasoplegia and all that. And you look for your bedside echocardiography for cardiac dysfunction. And based on this, if your patient is hypovolemic and fluid responsive, you will go ahead with a fluid challenge. If you feel that your vascular tone is the problem, if you feel your patient is vasoplegic, you can go for your vasopressors early. And if you feel it's a predominant cardiac dysfunction, you would go ahead with your dobutamine or inotropes. That's how I would simplify this. And this is basically what they have done in their algorithm as well. So something that we can definitely try a lot further in our resuscitations, if you're already trying this, just some fine tuning here and there would do. And that would be my takeaway from your Andromeda 2 trial. So I think that's all that, there's a lot more to discuss, but I think we'll wind up at that for now. Maybe anything else you want to comment on?
No, sir. Thank you.
Mehul, I just need to add one thing. Hi,
Ma'am.
Aravind, Surya here.
Hi.
Hi. The conclusion being, I think they are pretty much silent about the 30 ml per kg fluid. So you cannot conclude anything about the amount of fluid that you need to give for a patient in septic shock. Because if you look at the inclusion criteria, the inclusion itself is sepsitrica septic shock criteria,
Yes,
in
ma'am.
which they have given the patient fluid, almost
Yeah.
1 liter, I think. Then they had started the patient on norepinephrine. So still you cannot conclude anything about the initial 30 ml or 20 ml fluid. You cannot conclude based on this. But the further fluid resuscitation, if you are thinking like I loaded the patient with fluid, I started the patient with noradrenaline, still the patient is not responding. So before going for further loading with fluid or further increasing the inotrope support of the patient or vasopressor support of the patient, you can go for a personalized hemodynamic resuscitation. So I think we just need to modify the conclusion from our presentation that we are not speaking in terms of the amount of fluid that needs to be given, or we are not saying that you shouldn't give the patient fluid first, start the patient on inotrope, or you go with. You can use a personalized hemodynamic resuscitation for giving the fluids or starting inotropes. So that would be the conclusion, I think.
Yeah, I agreed. I think, like what ma'am highlighted over there, I think if you look at the baseline, it's actually all patients have actually received 1.5 liters at randomization. I think on an average in both the treatment and the control arm. So about the initial 30 ml per kg, like you said, we can't comment on that. It is about what happens further in the septic shock resuscitation. I think I would completely agree with that point. So I
Yes,
think
ma'am.
that's what you were trying to highlight, Nama.
Yeah, that's it.
Yeah.
Yes, ma'am.
But
Absolutely.
there's one very interesting thing that came up in the tertiary analysis. I know I'm taking a little bit more of time, but one of the things that came up really interesting was like you pointed out, there's barely a 250 ml difference between the both arms at the point of 6 hours from randomization. So the use of vasopressors, the use of RRT, organ support treatment is actually very similar between the two groups when you look at 6 hours. So there is what they postulate is that the whatever difference has come in outcomes towards the end is probably because of what happened after that 6 hours rather than during the treatment protocol duration. It is possible that these patients who were in the treatment arm, because it was an unblinded study, they probably they went for early weaning from organ support or whatever it is. It is possible that there has been an effect like that, which actually results in the outcome of mean organ support free days or hospital length of stay coming lesser in the treatment arm rather than this. Because the difference, if you look at it, the 6 hour point of time is actually very minimal between both groups. So we don't know whether that is what actually affected the final outcome. We are not sure about it. So that's actually a lot of food for thought in this study. That's what I said. There's a lot more to discuss in this trial, actually.
Yes, I agree with that because I think difference of 250 ml between both groups, that's not a lot of fluids, to be frank.
Yeah,
And
exactly.
I don't expect 250 ml to start, changing outcomes like that. That doesn't really work for adult patients. But anyway,
Yeah.
ma'am has also made some good points. So this doesn't really change the way we are practicing sepsis as far as this guidelines that we already have. But for after we go beyond those guidelines and when we go further into the resuscitation, there are some things that I think we can consider. Like there are some new things introduced here, like the diastolic blood pressure and all. I don't think anybody was really doing that before this. How useful that particular thing is, I'm also not sure from this particular trial. Also because of the bundle effect. But again, there are some interesting things here. I think maybe some further studies will look at the individual components, and we can draw some more conclusions from that.
Yeah, I think if you're looking at diastolic blood pressure, I mean, it's whatever the Everdac trial says, it's get an outline and then look at your diastolic blood pressure, look at your pulse pressure. I mean, those are important things. So, I mean, I know the Everdac trial says that it's okay even if you delay outline session. I mean, I don't agree with that. That's a different story altogether. But I would say go ahead with it and look at your diastolic right from the start. Look at your pulse pressure right from the start. Know what you're dealing with right from the start, and then I think that's gonna make a difference. So yeah, I mean that's just different, but still.
Okay, so anybody else want to say something? Otherwise, I think we'll just conclude. It's been a while. I think we've taken more the time than we anticipated, but it was a very good discussion, I feel. So even with the little audio breaks in between.
Yeah,
So,
I mean, I didn't understand. Yeah, sorry about that.
no, that's okay, sir. So again, I think a good number of people came. Usually, whenever I put up journal club, nobody comes. That is why I haven't done one in a long while. But it was good participation today, and I think I'd like to thank everyone, especially Arvind sir and Surya ma'am, for coming and attending this.